Good evening, everyone. Today I am going to talk about the antidepressant drugs. I will cover only the first part of the antidepressant drugs. And the atypical antidepressants are the drug of choices I will discuss in another slide. Okay. Coming to the depression is resulting due to your decreased monoaminergic like serotonin and noradrenergic activity. Because of the decreased monoamines in the brain, they cause depression. If there is deficiency of serotonin, if there is deficiency of noradrenaline activity in the brain, then depression will happen. So the drugs which increase the monoamines like serotonin, which can increase the noradrenaline, they can treat your depression. And the drugs which increases these things are called typical antidepressants. Suppose the drugs which can treat your depression by other mechanisms other than this, it's called atypical antidepressants. Today I will cover only the typical antidepressants, and tomorrow I will cover your atypical antidepressants with the drug of choice. So the typical antidepressants, it will increase your monoamines transmission by inhibiting the reuptake or inhibiting the metabolism. You know that by inhibiting the metabolism, there will be more monoamines. The monoamines will not be metabolized, so there will be it will be in the circulation for a long time. So that okay, you can treat the depression. What about the reuptake? What do you mean by reuptake? Let's see this slide. So this is serotonin neuron. Okay, the blue color is serotonin. It is stored in the vesicle. So when the action potential comes, it will get released into the synapse and it will act on the postsynaptic receptors. After the action is over, it will go into the, it will get reuptake into the neurons that will store in the vesicle. So the reuptake is to stop this process, to stop the transmission. If you inhibit this transporter, what will happen? It will be, the serotonin will be released in the circulation, it will not come back. So it will be staying in the circulation, it will do the action. So that's why we are giving reuptake inhibitors in such cases. So we have two reuptake inhibitors. One is tricyclic antidepressants. Tricyclic antidepressants inhibits the serotonin reuptake inhibitor and also noradrenaline reuptake inhibitor. But SSRI, selective serotonin reuptake inhibitor, will inhibit only this 5-HT reuptake inhibitor. TCA will inhibit 5-HT reuptake inhibitor and noradrenaline reuptake inhibitor. SSRI will inhibit only this serotonin reuptake inhibitor. Okay, this is the mechanism of action. So by inhibiting these reuptake inhibitors, so all the neurotransmitters will be in the synapse, will act on the postsynaptic membrane and act on the receptors and will do the action and will treat your depression. So this is the mechanism of reuptake, inhibiting the reuptake. So tricyclic antidepressants, they act by inhibiting the reuptake of both serotonin and noradrenaline. So this will results in your increase in the concentration of the neurotransmitters in the synaptic level. If you talk about bupropion, it's an atypical antidepressant. It can also inhibit the dopamine reuptake of dopamine neurotransmitter. Now your serotonin is released. Now your noradrenaline is also released. So they also they act on the postsynaptic receptors that you know. They also act on presynaptic receptors also. Okay, presynaptic receptor of serotonin is 5-HT1A. And presynaptic receptor of noradrenergic neuron is alpha 2. So they will act on these receptors. So if any neurotransmitter act on the presynapse, what will happen? It will inhibit the release of the neurotransmission. Okay, it will inhibit the release of the neurotransmission. By giving it for a long time, these receptors will get desensitized. Then they will get, then there will be increased neurotransmission. Okay. Simple mechanism. They will these neurotransmitters act on the presynaptic receptors. Okay, that is 5-HT1A here and alpha 2 here. On acting on these receptors, it will cause decrease in the neurotransmission. By acting on these receptors for a long time, the receptors will get desensitized and there will be increased transmission. So that's why the desensitization of the receptors to take place, it takes 2 to 3 weeks. That's why the action is delayed. So on a long-term administration, the desensitization of these receptors will occur and enhanced transmission is seen. So your noradrenaline and serotonin will act on presynaptic alpha 2 and 5-HT1A receptors. Alpha 2 receptors is present in locus coeruleus, that is noradrenergic neurons, and 5-HT1A receptors in serotonin, nucleus raphe magnus. So by acting on the presynaptic receptors, it will cause decrease in the firing of your locus coeruleus and nucleus raphe magnus, decreased transmission. But on giving for long-term administration, the desensitization of the receptors will happen, then there will be enhanced transmission. This explains your long latency of the antidepressant action of your TCA as well as SSRI. About 2 to 3 weeks, there will be a latency period. There will be no effect. Now coming to the TCAs. TCAs, there will be a selective action of your TCA. They can cause sedation. They can appear immediately. In the TCAs, we have BCM. Okay, that is called bupropion, meprotylene, and clomipramine. They will lower your seizure threshold. Okay, so name the antidepressant drugs which can increase your seizure or which can cause lowering of the seizure threshold. The answer is BCM. They can cause increase in seizures. Bupropion, meprotylene, clomipramine, BCM. And what is the problem with your TCAs? They can cause your weight gain. Weight gain is most important problem of TCAs. And another important property of TCAs is they are having anticholinergic property, and they are also having weak alpha blocking activity. And because of the anticholinergic activity, they can cause anticholinergic side effects like delirium, urinary retention, blood vision, constipation. They can cause postural hypotension. Because of your alpha blocking activity, they can cause postural hypotension. At toxic doses, they can cause cardiac arrhythmias also. So they are very dangerous because they can cause arrhythmias. They have very low safety margin. If you talk about Amoxapine drug is a TCA, they also act by blocking your D2 receptors. Okay, along with they also inhibit your noradrenaline reuptake. Along with they also block your D2 receptors because of blocking D2 receptors, they also possess antipsychotic properties. Because why it is having antipsychotic properties? Because it is metabolite of the antipsychotic loxapine. Loxapine is metabolized to a compound called amoxapine. So this amoxapine is having D2 blocking activity. Because of blocking D2 activity, it acts as an antipsychotic. And because of inhibition of the noradrenaline reuptake, it acts as an antidepressant also. And because of blocking D2 activity, can also produce extrapyramidal symptoms like dystonia, Parkinson's like side effects they can cause. They also cause convulsions. So amoxapine, they can block D2 receptors. They also inhibit the noradrenaline reuptake. They possess antipsychotic properties. It's a metabolite of an antipsychotic drug, loxapine. And because of blocking D2 receptors, they can cause extrapyramidal symptoms. They can also cause convulsions. In TCA, the drug called imipramine. They are also indicated for nocturnal aneurysms, bedwetting at night, particularly in very first to 1 to 3 years old child. They will do nocturnal aneurysms. So you can treat by giving imipramine to them. But the drug of choice is always desmopressin, which is an antidiuretic. It will prevent the diuresis. So what is the problem with your TCA? Because of inhibition of the noradrenaline reuptake inhibitor, more noradrenaline will be released. So they can cause tremors, insomnia. Because of inhibition of your cardiac sodium channels in your cardiac, in your heart, it can cause conduction defects, it can cause arrhythmias, it can cause hypotension. Because of anti-muscarinic effect, it can cause anticholinergic side effects like hyperthermia. Because of decreased sweating, it can cause hyperthermia, it can cause flushing, it can cause mydriasis, it can cause pallidiculitis, it can cause urinary retention, it can cause sinus tachycardia, constipation. Because of alpha blocking activity, it can cause postural hypotension. Because of histamine blocking action, it can cause sedation. Because histamine is it can cause alertness by activate your reticular activating system. By blocking histamine, it can produce sedation. Now coming to your SSRIs, selective serotonin reuptake inhibitor. They are now the first drug of choice for your depression, for obsessive compulsive disorder, for post-traumatic stress disorder (PTSD), bulimia, premenstrual tension syndrome, and panic disorder. So they are the drug of choice for your 6 indications: depression, OCD, PTSD, bulimia, and PTS, premenstrual tension syndrome, and panic disorders. These drugs only inhibit the reuptake of serotonin, not your noradrenaline like TCAs. So they lack anticholinergic properties, they lack alpha blocking properties like your TCAs. They don't cause sedation like your TCAs. They don't cause weight gain like your TCAs, and they have no propensity to cause seizures or arrhythmias like your TCAs. So they are more safer than TCAs. It inhibits only 5-HT, not adrenaline reuptake inhibitor. So they lack anticholinergic property, they lack alpha blocking property, they lack they don't cause sedation, they don't cause weight gain, they don't cause seizures or arrhythmias. They inhibit only the serotonin reuptake inhibitor, not your noradrenaline reuptake inhibitor. So by inhibiting these reuptake inhibitor, more of your serotonin will be released in the synapse and act on the postsynapse. So what is your problem with your SSRIs? Most problem is nausea. Next is anxiety, and followed by diarrhea. Diarrhea is caused because of the serotonin will act on 5-HT4 receptors. 5-HT4 receptors is in your GIT. It can act prokinetic. It can increase your peristalsis. Okay, that is the reason for diarrhea. And also it can cause inhibition of your ejaculation. It can cause sexual side effects because of it inhibits ejaculation. It can be given for the treatment as treatment for the premature ejaculation. One drug approved as dapagliflozin. Dapagliflozin is an SSRI used in the treatment of premature ejaculation because these drugs causes inhibition of the ejaculation. So these drugs used in premature ejaculation. One drug approved is dapagliflozin, and these drugs should not be given with monoamine oxidase inhibitors. Monoamine oxidase normally metabolize the serotonin. If you are giving monoamine oxidase inhibitors, serotonin will not be metabolized. More serotonin will be released in the synapse. So if you are combining with SSRIs, more serotonin will be in the synapse because more serotonin syndrome. So you should not combine monoamine oxidase inhibitors with serotonin, SSRIs, selective serotonin reuptake inhibitors. It can also cause akathisia. It also affects your platelet serotonin levels. Since the platelet also contains the serotonin, it can affect your platelet serotonin level also. It can cause abnormal bleeding. So if you are combining SSRIs with warfarin, the safest drug to give is SC. Remember SC, sertraline and citalopram. So coming to the side effects, nausea, anxiety, diarrhea due to 5-HT4 agonism. It inhibits ejaculation. Because of inhibiting the ejaculation, it can be used in premature ejaculation. One drug approved is dapagliflozin. It should not be combined with monoamine oxidase inhibitors because of serotonin syndrome. It can cause akathisia like your psychiatric drugs, and it also affects your platelet serotonin levels. It can cause abnormal bleeding. The safest drug to use with warfarin is SC, sertraline and citalopram. In the SSRIs, we have fluoxetine, we have fluoxamine, paroxetine, sertraline, citalopram, escitalopram. Fluoxetine is the longest acting drug in this family. It is metabolized to a product called norfluoxetine. That will retain your antidepressant activity. And fluoxamine is the shortest acting SSRI. So other drugs are paroxetine, sertraline, citalopram. And escitalopram is the most specific SSRI with less side effects, escitalopram. And paroxetine is the most teratogenic. So it should be contraindicated in pregnancy. Paroxetine should not be given in pregnancy. P should not be given for pregnancy. Paroxetine should not be given for pregnancy because it is teratogenic. So fluoxetine is the longest acting. It is metabolized to norfluoxetine that retains the antidepressant activity. Fluoxamine, shortest acting. Escitalopram, most specific SSRI. Paroxetine, contraindicated in pregnancy because of teratogenic side effects. Coming to MAO inhibitors, monoamine oxidase inhibitors. So we have two types of monoamine oxidase enzyme, MAO-A, MAO-B. So they are involved in the metabolism of monoamines. So MAO-A, so monoamine oxidase A, they metabolize all your most of your neurotransmitters like noradrenaline, serotonin, dopamine. They are mainly present in your intestines, liver, and peripheral nerve endings. So monoamine oxidase A present in peripheral nerve endings, liver, intestines. They metabolize all of your neurotransmitters, serotonin, noradrenaline, and dopamine. But monoamine oxidase B, preferentially metabolize only the dopamine. It is present in the brain, platelets, and liver. Monoamine B metabolizes only the dopamine, present in the brain, platelets, liver. What about non-selective monoamine oxidase inhibitors? Since its name says it's non-selective, it will inhibit both of your monoamine oxidase A and B. It will inhibit both of them non-selectively. So what are the compounds we have? Tranylcypromine, isocarboxazid, and phenelzine. They will inhibit both isoforms of monoamine oxidase irreversibly. And their antidepressant effects will take place around 3 to 4 weeks. And these drugs, they will exhibit large number of drug and food interactions. So the drugs in these families, tranylcypromine, isocarboxazid, and phenelzine. Important one are cheese reaction. The cheese, beer, and red wine, they contain the tyramine. Okay, the tyramine is indirectly acting sympathomimetic. They will cause release of your noradrenaline from the noradrenaline neurons to the circulation. Normally, the tyramine is metabolized by your monoamine oxidase A present in your intestine. So if it is metabolized, it will not absorb into the circulation or systemic circulation. But if you are giving monoamine oxidase inhibitors, non-selective, it will get inhibited. So tyramine will not be metabolized by this enzyme. So it will get absorbed by the intestine. So it will escape the degradation. It will go into the circulation and cause more noradrenaline release and cause more side effects. Hypertensive crises are called cheese reaction because cheese reaction. So cheese should not be given to the patients on long-term non-selective monoamine oxidase inhibitor therapy. So what is the drug of choice for the cheese reaction? It is phentolamine. Phentolamine is non-selective alpha blocker. Okay. Why we are giving phentolamine for cheese reaction? I told you tyramine is indirectly acting sympathomimetic. So after going into the circulation, it will release the noradrenaline. So the noradrenaline will go into your postsynaptic receptors, alpha 1 receptors. And acting on alpha 1 receptors, it can cause severe reactions, hypertension, heart rate, increase in heart rate, palpitation, tachycardia, everything it will cause. So it will cause cheese reaction. So to prevent this, what you have to give? Alpha blocker. So it will block the alpha 1 receptor activity. So the noradrenaline will not act on the alpha 1 receptors because we have given phentolamine alpha 1 blocker. So noradrenaline side effects will be prevented. Cheese reaction will be treated. So treatment for the cheese reaction is phentolamine. And what about the interactions of non-selective monoamine oxidase inhibitors with pethidine? Okay, pethidine is opioid for you are giving for painkiller. Normally, most of your pethidine is metabolized by monoamine oxidase. Okay, normally most of your pethidine is metabolized by monoamine oxidase. If you are giving monoamine oxidase inhibitor, then it will not be metabolized, and it will shift to other pathway. It's called normeperidine pathway. In this normeperidine pathway, it is only 1% of the pathway, and it will be metabolized. It will produce the excitatory metabolite called normeperidine. It is neurotoxic. It will produce seizures. Okay. Normally, your pethidine is metabolized by monoamine oxidase. Okay. 99% of the cases, it is metabolized by monoamine oxidase. Only 1% of the pathway it will produce normeperidine. If you are giving monoamine oxidase inhibitors, it will not be metabolized by monoamine oxidase. So the other pathway will get stimulated. The normeperidine pathway will get stimulated. Then it will produce the excitatory metabolite normeperidine. It is neurotoxic. It will produce seizures. So you should not combine monoamine oxidase inhibitors with pethidine. And if you give monoamine oxidase with SSRIs, will produce more serotonin syndrome. Reason I have already explained. So when you should give SSRIs, SSRI should be started at least 14 days after the discontinuation of monoamine oxidase inhibitors. So this time, the 14 days gap will allow the sufficient time for the regeneration of the monoamine oxidase because already inhibited. So for the regeneration to take place, it is take at least 14 days. So SSRI should not be given together. If you want to start SSRI, it should be started at least 14 days after discontinuation of your monoamine oxidase inhibitors. Coming to the reversible inhibitors of monoamine oxidase A. Moclobemide, it inhibits the monoamine oxidase A. It is used as an antidepressant treatment. It is also used as an treatment for the depression. So it will inhibit your monoamine oxidase selectively and reversibly. And because of the reversible and short action, it will not exhibit your cheese reaction with foods. So it can be used as an alternative therapy to tricyclic antidepressants for the treatment of depression. So moclobemide, it inhibits monoamine oxidase A. It will not produce a cheese reaction. It will not produce reaction with foods like tyramine. So it can be used as an alternative therapy for tricyclic antidepressants for the treatment for depression. And in tricyclic antidepressants, we have imipramine, amitriptyline, trimipramine, and clomipramine. These drugs will inhibit both of your 5-HT and NA. And the drugs which inhibit only the noradrenaline reuptake inhibitor is DAN, D-A-N, dasypramine, amoxapine, and nortriptyline. Okay, so imipramine, amitriptyline, all the pramines, trimipramines, clomipramines, imipramines, amitriptylines, they will inhibit both of your 5-HT and NA. The DAN will inhibit only the noradrenaline reuptake inhibitor. They are dasypramine, amoxapine, and nortriptyline. DAN. Okay. So we'll talk about phobias. If the people have panic attacks, specific phobias, and the fear responses, the main treatment is systemic desensitization. We have to desensitize such patients by gradual exposure to the feared situation. Okay, you should gradually expose to them to the feared situation. That is the desensitization is the best treatment for the management of specific phobias. And there is a drug called cycloserine we use in multi-drug resistant tuberculosis. And this drug can enhance the extinction of your fear responses. It can minimize your fear responses. It causes extinction of your fear responses with exposures. We can give cycloserine for such patients. So the normal management of specific phobias is systemic desensitization by gradual exposure to the feared situation. And the cycloserine will enhance your extinction of your fear responses with exposures. Coming to the antioxidant, what is this compound? It is also the serotonin reuptake inhibitor, but it can also has additional property like 5-HT3 antagonist and 5-HT1A agonist action. It is indicated for major depressive disorder. So serotonin reuptake inhibitor, antioxidant is serotonin reuptake inhibitor. Along with that, it has 5-HT1A agonist and 5-HT3 antagonist. It is indicated for your major depressive disorder. In case of post-traumatic PTSD, post-traumatic stress disorder, prazosin is an alpha blocker. Okay, you know that. Prazosin, terazosin, doxazosin, like that. Prazosin will decrease the nightmares and improve the quality of sleep in your post-traumatic stress disorder. PTSD, you can give prazosin. It will decrease your nightmares and improves the quality of sleep. Coming to MAO-B inhibitors, monoamine oxidase B inhibitors, we have serotonin. It is useful in Parkinsonism. It inhibits only the monoamine oxidase B. Monoamine oxidase B is present in brain, okay, brain, platelets, and liver. So it is also available as transdermal patch for the treatment of depression. So it is given for two conditions, one for Parkinsonism and one for the treatment for depression. It is available as transdermal patch for depression, and we can give orally for Parkinson's. It inhibits only the monoamine oxidase B. Coming to SNRIs. SNRIs means serotonin and noradrenaline reuptake inhibitor. Okay, this is also similar to TCAs. And why there is separate name as SNRI? TCA also inhibit the serotonin reuptake inhibitor. TCA also inhibit your noradrenaline reuptake inhibitor. And then why it is called SNRI instead of TCA? Let's see. The drugs in this family is venlafaxine, milnacipran, levovilnacipran, and duloxetine. They inhibit the reuptake of serotonin and noradrenaline. Okay, but why they are called SNRIs, not TCS? Because they lack anticholinergic properties and they lack alpha blocking properties like your TCS. TCS have anticholinergic property. TCS have alpha blocking property. But these SNRIs, although they block this, they share the same mechanism of action, but they don't block alpha receptors and they don't have anticholinergic mechanism. So they are safer comparing to your TCS. So we have SNRIs, serotonin and noradrenaline reuptake inhibitors. We have venlafaxine, milnacipran, levovilnacipran, and duloxetine. Coming to the mirtazapine, it is called. It is also blocking the noradrenergic and specific serotonergic antagonist. It has separate entity. I will discuss one by one. Mirtazapine, also known as noradrenergic and specific serotonergic and antidepressant. Noradrenergic, specific serotonergic, antidepressant. NSSA. So I will discuss the rest of these drugs in next class. Thank you for your kind attention.